Hello, this is Manuel de la Rosa translating the lecture of Dr. Juan Alberto Fernandez under the title Osteology Guidelines for Advanced Bone Regeneration and Implant Therapy, Part 2. This will be on surgical and technical considerations. So, as autogenous bone is considered the election, the gold standard of bone grafting, I understand that there are several other materials that we can use, or bone grafts that we can use, that will also work fine on certain cases. Now, there's other type of grafts that are called allografts, which are from the same species but of a different individual, or we could have some bone grafts derived from animal tissue, like these are called xenografts. They're from a bovine origin, or coral hydroxyapatite, or we can have some alloplasts, which are synthetic materials or synthetic grafts that we can use as well. I think the autogenous is the most ideal, but we could also use some other ones like the allografts. We can use allografts, and I think if we use allografts, we can add some cellular component so we can have a better type of graft. So what is a allograft? An allograft, freeze-dried allograft, is something that comes from another individual, and we could use it with a good success rate in our surgeries. This bone is derived from a cadaver. On the early time after the death of the patient, this bone tissue will be obtained and will be worked on a certain lab with all the security measurements, and it will be ready to be used on a dental scenario. And it will have a collagen matrix and a mineral matrix as well. This will give some physical characteristics that will allow it to be very useful in the dental field. I would like to thank to Miguel Velilla, who I had the privilege to meet, and he explained me all the work of the stem cells on the adults and how they work on the healing. He has been an inspiration for myself. As I mentioned previously, we will see the characteristics that this bone has. I would like to show you a very simple case. Old patient, she's older patient, above 80 years of age, and she's in treatment with biphosphonates. And as you can see in the picture, it's not so hard, but I recognize that during the surgery, what really preoccupied me was the type of bone. There was a bone with no bleeding. It looked like a dead bone. I opened a flap, and after we sent the tooth to biopsy, I start working on the bone graft, allogenic bone graft from the bank of tissues, and I start working outside with some rotational instruments to get the medullary bone component and separate the plate of bone. I like to obtain some thin cortical laminates of bone, as well as not so thin cortical laminates of bone or plates of bone. So what I will do is place the bone graft with spongious bone, and then we will fix the thin cortical bone graft with some fixating screws. And on top of these, we will use some bone graft, cortical bone graft, transform in small components so that we can have a complete layer of bone covering the regeneration area. Now it is interesting to see how after 3 weeks a small dehiscency occurs in the soft tissues. And what we did is a rotary positional flap from the palatin, and we resutured these during this appointment, and after 1 week we have a complete closure of the area. And normally what we do is we wait 16 weeks and we reopen, and when we open again 16 weeks after the initial surgery, now we have a bone which is really red in color. It bleed like a normal bone. And at this moment we remove the fixation screws and we do a little biopsy to observe in the histology. And we can see in the histology the new bone formation. So we can understand that these allogenic bone graft had an osteoinductive capacity that has allowed us to create a new bone. So, as we all know, we are not giving something new to the literature or to the science of dentistry. We're just using some old concepts in bone regeneration, giving it the sufficient time, and we will know we will get a regeneration. Now, we know that what we can also add to these bone graftings is some medullary bone liquid with blood obtained from the iliac crest, and we will have this mineral component added to the and cellular component to the bone graft, which will mediate the healing capacity and allow us to have a regeneration with the stronger components. But what are the ideal characteristics that we look for when we are working with a grafting, with an osseous graft? I think going with the article by Cutter will be first a biocompatible material, an absence of an immune response. It should induce a new bone formation. It should resorb after a certain time. And it should have as well some radiolucency. It should be resistant to an infection process. It should be with a wide disposability so we can use it on wide cases. And it should be on a low cost. This was published by Cutter in the year 2006. And these are the characteristics that we look for on the bone grafting. We will go into details in every one of the aspects of the bone graft. Now, talking about the biocompatibility, I think the article by Ruben Spinetto in 2012, it's outstanding. So what he did is he did some bone grafting and divided autogenous bone graft and allogenic bone graft on the same patients. And he had a group of patients he evaluated the interleukins and the interferon to see if there are differences. Interestingly enough, he found no difference on the healing response on either one of both grafting materials. So he concluded that any one of these two types of bone graft are very appropriate for gutted bone regeneration. Now, another point that has grown a lot is the confusion that has created on the survival rate and the success rate. I think these are different concepts, and this is something that is not a good indicator of the success of gutted bone regeneration. On this sense, Francesco Carini analyzes the survival in a retrospective study on implants in restored maxilla grafted with fresh frozen allogenous bone. These implants were loaded after 4 and 6 months. And what he found was that even though there is a greater loss of bone, it is also a very helpful tool for gutted bone regeneration before the fixation of the bone. Now, in the mandible, the same author recognizes that the behavior of such bone graft is adequate to support fixation, but as well, he insists again that there is more marginal bone loss. And the same author compares on 88 implants loaded at 4 months on the maxilla and on the mandible. He did the bone grafting, 4 months waiting, and then he did implant insertions, 4 months waiting, then the final prosthetic rehabilitations on an average 27 months and a final checkup. And he encountered a very good percentage of results. So he understands, and he concluded that the use of allogenic bone graft was a good material to use with similar results to that with autogenous bone graft. Now, Simone Lumetti made a study in which he did a randomized controlled trial in which he compared autogenous bone grafts for maxillary horizontal ridge augmentation in patients with Cawood and Howell class 4 atrophies. Results he obtained were very evident, but something I think is very interesting is in this paper he uses different loads of doxycycline, and as you know, the doxycycline will be impregnated in the new bone formation, and what he found was that the behavior of the autogenous bone graft was better than the allogenic bone material. So even though we know that the allogenic bone graft is useful, we also see that the autogenous bone graft behave better on this paper. Now, the papers by Rubens and Spinetto are definite because he did a comparison in fresh, frozen only bone blocks with autografts in human maxillary reconstruction. What he concluded is that human fresh frozen bone block show clinical compatibility for grafting procedures, although associated to slow remodeling process. He concludes that further studies are needed to define at long term that remodeling process chronology, as well as the clinical longitudinal results for the fresh bone. On this paper by Ruben Spinetto, we can see that the radiologic behavior of the bone grafts is very satisfactory. And this is, as I was mentioning, something that we look for in the characteristics of an ideal bone graft. On this sense, on this paper, Rubens and Spinetto, 1 year after, he used and do the same. And he encountered some results that were similar to ones that he encountered before. And he did some implant placement, and then he took some biopsies at this time, and he found that autogenous bone graft behaved better than the allogenic bone graft. And this is the histology process of the allogenic bone graft and the autogenous bone graft. Now, this author is not using autogenous bone graft obtained through the aspirator tip. Now, we will now change in gears, and we will now see Michel Giacotti's work. And he used an allograft, but it is not a freeze-dried bone allograft. But what he did, and he did a different type of bone grafting. What he developed was a new model for bone graft in which, from an image of a CBCT, he will work on a bone graft and adapt it outside the mouth of the patient, and then he will sterilize this bone graft and then come back and go to the patient and place the graft in the patient. According to Giacotti, the advantage of this technique was that you reduce tremendously the clinical time and will have a major tolerance index by the patient. For me, Dr. Castana was the one who showed me this technique, and him with Miguel Velilla have initiated me in the appassionated world of allogenic bone graft. Michel Giacotti did some follow-up of cases, and he observed that the result obtained was very successful. Afterwards, he worked on something that was not only general from a physical model, but he also worked with the CAD-CAM and how the CAD-CAM will create the model of the ideal shape of bone graft that the patient will need. And the results obtained are very, very good. The inconvenience of this article is that it was one single case, was a report of a case. Some of the authors like Shell, Schle, and Daniel Rothamel did several case reports with very good results. Now, as of today, what we have seen up till now were small papers with case report or several case reports. But as clinicians and as scientists, I think we should go into more structurized literature or research so we can inform our patients and our colleagues on deeper evidence. And we know from different papers that the use of allogenic bone grafts have a low level of scientific evidence and are still in doubt to be considered an ideal standard as the autogenous bone graft. As of now, we have only talked about allografts. And I must remember you that all these allografts have no cellular component. So when we need or we want to give a cellular component to these allografts, we must add an external material so that we can have the cellular component of these bone grafts. Now, these cellular components could come from a peripheral bloodstream. But we know that on the normal bloodstream, the stem cells, the quantity of stem cells is very limited. On a paper by Terence Rich, the mid-90s, what he did was compare the presence of osteoprogenitor cells on the peripheral blood vessels as well as at the alveolus after an extraction. And he observed that there was no difference, no significant difference. So it seems like that the peripheral blood as well as the alveolus bleeding will not give a sufficient amount of pluripotential cells. Now, the paper in 2005 by Sultan talks about a new perspective as a new platinum standard for bone grafting. And he talks about a medullary aspiration system in which he will achieve the quantity of autogenous stem cells that in combination with osteoconductor grafts will increase the regenerative capacity. In this sense, the same papers, the same authors determine the existence and quantity of stem cells in an aspiration, on a medullary aspiration, as in the blood, endothelial blood or peripheral blood. So the ability of the multipotent cells to form osteoblasts from bone regeneration makes transplanted bone marrow an optimal option for regeneration. So the use of bone marrow has been considered as an alternative in which we can generate the new bone formation. And as we can see in this video, we can see what we're looking for, which are the cells that have the capacity of transforming to new bone formation. And these are endothelial cells, adipocytes, and osteogenic cells. I think we should be cautious in analyzing the literature to see what are the different techniques that we have to obtain mesenchymal cells from the adult. And again, the literature did not reach any significant conclusion as to the most predictable model in a stem cell. Here, as I mentioned previously, Muna Sultan is looking for a cascade of cells as cytokines and growth factors that interact in the regeneration. And they investigate if this cascade, immune cascade, can occur after a medullary aspiration. And it looks like if the medullary aspiration technique is a good technique to gain growth factors that will allow us to have a good regeneration. So let's talk about the bone marrow aspiration technique. And this is how it is done by a paper by Dennis Myler and Muna Sultan. They will take these from the anterior portion of the iliac crest, and they will have a portion of the bone marrow aspiration, 1 centimeter, and this material is the material that we're looking for. That this material that has the multipotent stem cells that will allow and aid on the regeneration process. Now, this paper by the same group of authors, we can see how the bone marrow aspirate behaves. And what they found is that the bone marrow aspirate is safe and easy to harvest, it is inexpensive, and it serves a number of functions at the bone grafting site. It will provide cells that can differentiate into bone cells, and influences the tissues adjacent to and add to the recipient site to regenerate bone cells by activating the body's ability to form new bone. It also supplies growth factors needed for bone formation and angiogenesis. So the theoretical model for bone graft success, by this paper by the same group of authors, I think is very crucial. And they explain how different techniques have developed to isolate the stem cells, and they analyze certain points that are questionable. The questions are if the quantity of the bone marrow aspirated from a given donor site increases the number of stem cells and progenitor cells available for use in bone grafting. However, research has demonstrated that the greatest volume of stem cells is contained within the first 1 to 4 milliliters of bone marrow aspirated from any given donor site. So 1 to 2 milliliters of bone marrow aspirate is usually sufficient to saturate the amount of resorbable graft material needed for most oral surgical procedures. So if a larger volume of bone marrow aspirate is required, it should be harvested from a second site. So it makes no sense to get a bigger amount of bone marrow aspirate. So if we need a higher amount of stem cells, we should go to a different site to obtain the second bone marrow aspirate. And if we centrifuge the bone marrow aspirate, will not isolate the desired cells. It will concentrate all nucleated cells. So the risk of death for these cells will be increased if we centrifuge as well as the metabolic materials that will come out from the persistence of these cells in a reduced medium. Carbon dioxide and urea will increase as well if we use this, if we augment the volume or the concentration of the cells that we'll inject in the graft. The third point, very interesting, is increasing the volume of bone graft material at any given graft site improves the chances for a graft success. And they presented this formula in which they explained that the thickness of the graft affects the viability of the cells at the center of the graft. The greater the graft volume, the greater the distance between the center of the graft and the vascular supply. So, none for autogenous bone graft or allogenic bone graft, we should not increase the volume of bone graft or aspirator bone marrow. It seems like the evaluation of bone biopsies with routine histologic staining is an effective method for evaluating bone graft efficacy and surgical outcomes. And they conclude that when they analyze the behavior of this technique with different scenarios and different materials, and they found how the use of the aspiration technique of the bone marrow and compare these with alloplastic material, they find that the utilization of the bone marrow aspiration will increase the capacity of regeneration of the allogenic bone graft. So when the bone marrow aspirate containing adult stem cells is mixed with bioengineering graft materials, it will provide a scaffold to support the proliferation, differentiation, and maturation of the stem cells. Another paper by Susi Lacerda, they found that if the cellular component of the medullary bone graft can be associated with bone marrow osteoblastic cells in bone defects, a much better result will be obtained. And up till now, what we have done, we have analyzed that this distinct characteristics that a dental grafting material could have as an ideal material. And the last point, I think, to consider will be the economical price, the economical aspect of the graft. If we evaluate the different techniques or possibilities of bone graft techniques that we have, we will see that the autogenous bone graft have a much lower price. It's great malleability and it's great behavior biologically and histologically. So I think that the combination of allograft with bone marrow aspiration will be the ideal alternative for the autogenous bone graft. on the conclusions that I would like to come, as published by Belija, is that this type of therapy, as well as any other therapy that we perform, should be very well evaluated to see the risks. And another very important aspect is that the technique that we will use is open to the dentists. But I would like to ask the dentist to be cautious, because it is not something easy, and we should take our precaution to see if we understand what we're doing and we understand the different biological aspects that we're working with, so we can perform a good work on the regeneration. Now that we have reviewed the scientific evidence of the different bone grafts and its healing behavior and alternative of autogenous bone graft, we will now see what are the pillars of these exercise or these type of techniques in my office. As you can see, these pillars have all been based on clinical and scientific evidence. I have read all these papers, and I usually follow all these concepts because all these people like Benilla and Castan have opened my eyes to understand how guided bone regeneration and the biology works, and how we can push the different development of new techniques that I'm sure in very short time will change completely the way regeneration is understood and performed today. And talking about what is my philosophy in the management of all the techniques that we have seen today, there is a concept that I like, and it is called bifunctional sculpturing of the bone graft for a three-dimensional augmentation of the atrophic posterior mandible. What we do is we take an autogenous bone graft and we remove the sponges part of the bone graft, and we will add PRF. And what we will do is we will have this graft that will have the thickest and the strongest part on the crestal area, and the whole cancellous bone component will be completely removed from the block. Now this will be mixed with previously collected medullary chips and enriched with the platelet, the PRP, to form an autogenous mixture. After these procedures, a thin convex cortical layer remains from the original block, which is easily narrowed and sculptured to stimulate the convex feature of the natural alveolar ridge. Then we will do the small perforations on the corticals to enhance the porosity of the mandibular cortex for the osteogenic cell lines. After these has been fixed with the screws, we will then be ready to close the regeneration area. So once we have this perfectly fixed, we can close the area and allow these to heal by itself, not before placing the aspiration of the stem cells. So the whole cancellous bone component is completely removed from the block, as I mentioned, and mixed with previously collected medullary chips. So all these structure, with the aid of the aspiration stem cells, will have all the cellular components needed for the bone regeneration. This is a small video how we get the aspiration of the bone stem cells. And this is how we inject the stem cells that will allow us to achieve the regeneration, aiding on the bone blocks that are needed for the regeneration. So from the bone graft that we obtain, we will use the part that we consider the best, or the one that we can suit or adapt better to the area that we need to regenerate. So, as we understand, the cortical will be like a cover sheet over the medullary portion of the bone, which will give us the medullary portion, the greatest aspects of regeneration. And the cellular components on the bone graft are the same as the other graft, autogenous bone graft, that we have spoken about in this lecture. Now we will see some cases in which we have used these techniques. In this sense, I would like to start with a simple case of a patient, not so easy, because he had an adenoma and has been intervened, and he is in a hormonal therapy, and he is very afraid of surgery. Look at the maxillary lateral incisor with the periapical lesion and a bone loss, periodontal bone loss as well. And we have done periodontal therapy, and on the right side we have seen that we have lost the first molar, and he is about to lose the second molar as well. And the third molar was considered as well to extract. We can see the moderate defect on the vertical component, and we should see that we will intend to gain a vertical and horizontal amount of bone. So we use allogenic bone graft with the medullar aspiration, and we will decorticate this bone and use the medullar portion of the bone to place it on the sinus grafting. Watch on the if you can see on the left side picture, that I have respected the papilla so I don't lose any of the height of the tissue. And this is after the sinus lift, how we adapted the bone graft, the cortical bone graft, allogenic bone graft. And once we have given the satisfactory form, we have made some perforations where we will introduce the stem cells obtained from the iliac crest. Observe how we have achieved a correction of the discrepancy of the bone levels, and we have as well done the sinus lift, placing some new bone inside the sinus area. In this case, I would have enjoyed doing the sinus lift a little more towards the anterior portion as well, but I had the risk of damaging the tooth on the anterior, and that's why I didn't intend it to go further forward. I do a systematic suture or a horizontal mattress suture with polyglycolic acid and a monofilament suture that will retain very low level of plaque and bacteria. And we have used it very, very well. And this is the healing. And after 16 weeks, which is 4 months, we will go ahead and place the implants. I did some biopsy. And this is the area where we're going to place the implants. And I took advantage and did a biopsy. And what we can see on the histology is that we have osteocytes present and rests of allograft that have not been yet resorbed. But they're in the process of resorption and new bone formation. So the allograft has a remodulation sequence that is lower in rate or in speed than that of the autogenous bone graft. We will see one more case that I think it is very interesting because it will take into consideration almost all the techniques that we have talked about today. It's a patient of 42 years of age, and she had a combined Kelly syndrome, in which she has been completely edentulous since she was 14. She has had some implant placed in the past, lost them in the past, and this is how she came. And what took my attention was that she was comfortable with her denture, but she wanted a better support to her face. So when I saw her, I told her I will give her for free the mandibular treatment if she will allow me to do the maxilla, treat her, do the guided bone regeneration, and do the implant placement. The patient, as I mentioned, had some implants placed and she started losing them. And the only implant that she had left was perforating the nasal cavity. And she had also a perforation to the maxillary sinus on the right side. You can look at the implant and how it is touching inside the nasal cavity and the maxillary sinus. So the implant was removed. Look at the aspect at the time of implant removal. And what we decided to do was to place some connective tissue graft with 2 tissue expansions. So our idea was to increase the soft tissue volume as well as to expand and gain a good volume that will facilitate the regeneration of bone in the future. So what we did is we allowed the keratinized tissue to be covering the area, and we suture, and this is a healing. The healing is running really well, but after 3 weeks the tissue expansor of the left was exposed. And what happened was that we had a healing area or a scar, so we had to remove the expansor. So we did a new connective tissue graft. And this is what we had after 2 months of the expansors, tissue expansors, and the connective tissue graft. The situation has improved. The patient, I must say, used the complete prosthesis after 48 hours after the surgery. She has used it ever since up till today. This is the lower arch and how the 2 implants that she had were in a very bad situation. Now look at the maxillary, at the maxilla, and how the right maxillary sinus was getting cleaner after the removal of the implant. And here I would like to share this concept of biosculpturing. And what we are doing is that with the cortical plates of the bone bank, we can rebuild all the maxillary alveolar process that the patient was missing. So what we'll do is we will join them in a V shape and only fix with the fixation screws, and we will then do minor adjustments with an osseous burr on the bone graft, so we can have the dimensions that we consider ideal for the bone graft. We will also then place the PRGF in place a tissue that, in my opinion, has much better quality. And it is at this time where we will apply the stem cell aspiration, which will allow us to gain the regeneration that we need. This is a time of surgery. You can observe how on the image on the right, both maxillary sinus are very well and are perfectly pneumaticized and moved to the new position. And it is at this moment that we are planning to do some reposition of the inferior alveolar nerve and move it so that laterally, so that we can place some implants, and we will do the transposition technique bilateral. We can observe how some weeks after, 16 weeks after of bilateral maxillary sinus and elevation of the premaxilla, we can observe a vascularized new bone, very little resorption. And this bleeding aspect gives us the certainty that we have a viable, vital bone. And when we evaluated histologically this bone, we see that we have a high activity of the collagen cells, and this gives me the idea that this is working very well in the healing pattern of the bone. So we see new bone formation. So this gives me higher expectations. So when we go to the lower arch on the same patient, we did a inferior alveolar nerve transposition towards the buccal. We get access to the mental nerve, and then we move the nerve towards the buccal, and then we go ahead and place the bone graft so we can aid in the height and the width. So this is how we have the mental nerve exposition, and we must identify the incisal branch and then the mental branch. So once we can move the nerve, we can go ahead and gain the regeneration process. And again, what we're going to do is use the allogenic bone graft. And this is the area where we had the regeneration. We now do the 2 osteotomies. And we do sponges bone graft, and we do the implant placements combined with new regeneration, and place the 10 implants on the maxillary arch. And what we did in the lower arch is we did a lot of bone grafting with the idea of having a immediate loading of the maxillary arch. I'm sure you will be able to follow this case because I will give you the chance, and as soon as I have the final results, I will publish them on Dental XP. I would like to thank you for the attention. I know these minutes have gone long time, and I hope at the end you will gain a good knowledge of these techniques that we're using. And I must go back to Dr. Mish, because I still think the gold standard in bone grafting is the autogenous bone graft. I think it's going to be hard to find a substitute for the autogenous bone graft. And I think that when it's necessary, we should continue using the autogenous bone graft. But when possible, the combination of autogenous bone graft as well as tissue modifiers or biological modifiers will allow us to have an improved technique and have a greater chance to obtain a true regeneration. So, and the multiplicity of the different options that we have, and I think that is where the excellence stands. It is frustrating to inherit a case where grafting was attempted using bone substitute when autogenous bone would have been the preferred choice. So I would like to go back to this table that I showed you earlier in my lecture today. And I consider, as I just mentioned, that the autogenous bone graft still is the gold standard. And as an alternative, the allografts, in combination with the stem cell aspiration, will be the choice that I will go for. We also have xenografts or alloplasts that can be used in combination with the previously spoken grafts. But I prefer the autogenous bone graft and the allografts. Going back to what we have already seen, the cellularity that we are providing with the metal aspirator, I think, increase the osteogenic potential of our bone graft. So, on every case that we perform, we should analyze the options that we have and try to give the patient the ideal one with a stem cell activity so that we can gain a higher degree of regeneration on a safer basis. Now, the technique that I used to speak about biosculpturing, in which we will utilize the cortical plates of the bone graft, and with these we can fix them and inject the bone aspiration. I understand you will have a lot of questions, and I'm sure we will be able to answer them all. I hope with my lecture I have opened your eyes and opened your interest. And I'd like to thank Dental XP for allowing me to present on this nice platform. And I wouldn't like to close my lecture without saying that we still are short of the learning process. And in some years, when we're using these new techniques, still there will be some questions that we might not have the answer at this moment. And the longer and the broader that we understand and study, the better we will do with the results. I would like to say thank you, and it's a pleasure to be with you in this platform today.